obviously there's going to be some adverse effects that need to be monitored for. What are those, and how do you monitor for them?
Yeah, sure. So obviously, anytime we're doing treating patients with kidney sparing approaches for the upper urinary tract, we're doing multiple ureteroscopies, we're doing multiple manipulations of these patients, and adding this chemotherapy or adding things on top of that, doesn't come, like you mentioned, free of side effects. And so there are incidents and reports of obviously ureteral stricture, upper urinary tract stricture, hydronephrosis. And so I think it's very important for us to talk about that with our patients. And it probably also, for myself, it gives me a reminder of how important it is to talk to my patients who are just undergoing ureteroscopy with laser ablations about that same thing, because obviously it's definitely a risk there. But discussing, the incidence of flank pain or fevers, chills, anything that would make you lean towards thinking you could have an obstructive symptom, that could be a sign of a stricture. Now, personally, I've treated a lot of patients, and I've treated them all, or not all, but a large chunk of patients with the nephrostomy tubes. And I do believe personally, and in some retrospective personal data and multi-institutional data, that risk of stricture is much reduced with a nephrostomy tube versus ureteral catheterization.
Excellent. Are you doing the nephrostomy tube outpatient when you install it?
I do it in the office setting.
That's great. That's great. In terms of mitomycin C bladder installation at the time of nephron sparing surgery, what are your thoughts on that?
Yeah, so there's no trial or anything to tell us that we should use an intravesical chemotherapy at the time of doing ureteroscopic ablations or anything like that. I do personally, oftentimes these patients have bladder as well, or lower urinary tract recurrences. When I do my bladder cancer, I actually use gemcitabine. And so oftentimes if patients have ureteroscopic ablations, I will use an immediate post-op course or immediate post-op dose of gemcitabine in the recovery room. Right. And I think that comes with me to say as a reminder to people that this mitomycin for pilokalicil solution is not an immediate adjuvant therapy. That doesn't happen in the operating room. It doesn't happen in the recovery room. It is, you find your patient, you discuss this with him as an outpatient, and then it's done as a 6-week induction course therapy.
Last question, I guess, going back to, if for the private practice urologist who's kind of considering implementing mitomycin C as a thermal gel, they're nervous. They don't know, like, they haven't used it before. Maybe they're not around a center that offers it, but they now know about it. So what would you advise them? What are some things that they should that would help them consider it further, et cetera?
Sure. The biggest thing I would say is this is not something that is trying to take surgery away from surgeons. And I think that as surgeons, kind of at the gut of us, there's always this fear that there's going to be some sort of, therapeutic that's going to take surgery away. I make jokes about that to my patients. That's not going to happen, right? There's plenty of patients to operate on all the time. So my first note to anybody out there considering it is you don't have to change what you're doing in your practice already, right? You just add this into it. You're already seeing these patients. They're not common. It's a rare disease, but you're seeing the patients, you're finding them, you're doing these big ureteroscopic ablations, yet the recurrence rate's high. It's pushing 60, 65% is the recurrence after these ablations. So, we've been waiting for something else. Patients are begging for something else. And for that something else, I don't mean, a nephroureterectomy. And so this is just one extra thing to put into your armamentarium that you don't have to change your already practice of what it is. it instills very familiar to us as urologists. We are used to doing things once a week for 6 weeks. We're used to letting people heal up for a couple of weeks after an operation or an ablation or resection before proceeding with those therapies. We're used to having to take them back to the operating room to repeat, look up inside, right? And so it's
Sure.
really not that different.